today's webinar session. October was declared Breast Cancer Awareness Month. To commemorate it, Society of Surgeons of Bangladesh has arranged a webinar series. Today is the third and final session, enlightened by presenters from both home and abroad. We are fortunate to have Professor Konok Kanti Burwa sir, Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, Dhaka, as our chief guest. And today's program is graced with the presence of our panel of experts, Professor Sanwar Hossain sir, Director of Medical Service, Senior Consultant, General Surgery, Spire Hospital Limited, Dhaka, Professor Dr. Muhammad Yaqub Ali, Department, Shohid Sohrawardi Medical College and Hospital, Dhaka, and Professor Dr. Tariq Al Nasir, Chief Medical Officer and Director, Lab Medicine, Imperial Hospital Limited, Chattogram. Professor Subhash Mujumdar, Professor and Head, Department of Radiology and Imaging, Chittagong Medical College and Hospital, Chattogram. We are grateful to all you all, sir, for giving us your precious time. Today's program is chaired by Professor A. J. Tohidul Alam sir, President of SOSB. Now, I request Dr. Mohammad Nur Hussain Bhuiya Shahi sir, Secretary General SOSB, to deliver his welcome speech. Professor Nur Hussain Bhuiya Shahi sir.
Thank you very much, Dr. Saira Banu Shivli. This is the Breast Cancer Awareness Month, everybody knows. We have the three scientific seminars arranged in this month. The first one is the 14th, and second one is the 21, and this is the last one. I must give thanks to all the speakers, those who have delivered their speech previously, and also to the speaker, chief guest, or senior faculties here. I think today's discussion will be more beneficial for the all of the junior surgeons, also those who are dealing with the breast cancer surgery, and I think it is beneficial for communicate to the next breast cancer screening program to participate in this program. Thank you. Surely, and go to speaker, please. Here I also give thanks to the
beauty and motherhood.
Anything wrong?
Dr. Sarah, continue, please.
Breast symbolizes femininity, beauty, and motherhood. Many times due to section or mastectomy instead of breast conserving surgery. As a result, the patient feels formed, loses self-esteem. Our first topic is breast conserving surgery versus mastectomy, Bangladesh perspective. And I request Samia Mubin, Department of Surgery, BSMNU, Dhaka, to present her topic. Dr. Samia Mubin. Dr. Samia Mubin, can you hear me?
Thank you. At the beginning, I want to thank the Society of Surgeons of Bangladesh for giving me the opportunity to speak in this auspicious occasion. So the Society has very beautifully celebrated the Breast Cancer Awareness Month, the month of October. And to commemorate this, we are also, by sharing our knowledge, and we are also increasing the awareness among ourselves. show my respect to our chief guest, Professor Kanok Kanti Borua, and all my senior teachers here. I'm very fortunate to be able to talk in front of you. And I'm also very much delighted to have the honor to be the presenter in the same platform with Professor Diptendra Sarkar, a very learned person from our neighboring country. So my topic of discussion is mastectomy or breast conserving surgery, Bangladesh perspective. So this is me. I am working as associate professor in surgical oncology division in Department of General Surgery, and this is my unit. We all know that breast cancer is a global enemy. Breast cancer is now the leading cancer in female globally, and 1 in 8 women will have breast cancer in their lifetime, which is a very big number. In 2018 only, there was more than 2 million newly diagnosed cases. Since the early 1990s, the breast cancer incidence rates have increased by 24% in the United Kingdom in females in the 20 years. So there is a rising trend of breast cancer in the world. And incidence of malignancies is similar in Bangladesh also. This is from our admitted patients in BSMMU, and we see that the most common malignancy admitted is the breast cancer. We know that the treatment of breast cancer is a multimodal, multidisciplinary treatment. We need surgery, chemotherapy, radiotherapy, hormone therapy, and targeted therapy. And we are talking about the various aspects of surgery today. So surgery is the main modality of treatment for breast cancer. And here we can see there are various types. We can do lumpectomy. There is options of wide excision. There is option of quadrantectomy, and of course there is mastectomy. And mastectomy with axillary dissection had been considered to be the only modality of surgery for breast cancer for many, many years. This is an instrument that used to be used back in 16th century to do the mastectomy for cancer breast. And the mastectomy has evolved over the years, and there were various studies regarding the mastectomy and the treatment of breast cancer and the survival of breast cancer. Here we can see from the 19th century picture showing the en bloc resection of breast cancer from an American surgeon. So there has been different types of mastectomy: Halsted radical mastectomy, modified radical mastectomy, simple mastectomy, toilet mastectomy. We all know about this. And this illustration is from William S. Halsted, who illustrated the radical Halsted mastectomy. So these are the pictures. In the first picture, this woman is very many years after undergoing radical mastectomy, she lived with this ugly scar in the first picture. And the second picture, we can see there is a big wound for radical mastectomy. And in the bottom 2 pictures, these are not radical mastectomy, but the scars are not very good looking. So the treatment of breast cancer has started to evolve from mastectomy now, because the incidence of early breast cancer is also increasing. The incidence of early detection of breast cancer is increasing because of the improved screening programs. There is better imaging facilities, and there is, of course, very important increased awareness among women. And most of the screen detected tumors are impalpable. So these are some examples of screen detected tumors. We can see the mammographic. We do the screening by mammography, and mammography pictures of very small, tiny tumors, and which are clinically undetectable. So a normal woman who does not have a lump in her breast and who does not have a symptom, when she goes for screening and she is diagnosed with a small, very tiny tumor which she cannot even palpate, she is not always very willing to undergo mastectomy and run with this altered body image for the rest of her life. So the goal of treatment for breast cancer has been modified. So so the main goal of treatment is to treat the cancer and also to maintain the cosmesis of the woman. So this is a very learned man, an Italian lawmaker and a doctor. He is Umberto Veronesi. He was an Italian oncologist, physician, scientist, and politician. He served as health minister for many years, and he is very internationally known for his contributions on prevention and treatment of breast cancer throughout a career spanning over 50 years. He invented the quadrantectomy and opted for limited surgery in the breast cancer, and he also was a pioneer for sentinel lymph node biopsy for breast cancer. So for breast conserving surgery, it is a balance between good cosmesis and good local control of the disease. The aim of local treatment of breast cancer is to achieve long-term local disease control with the minimum of local morbidity. So why we do the breast conservation? Because it produces an acceptable cosmetic appearance in the majority of women. Various studies have shown that the conservation of breast results in lower level of psychological morbidity, less anxiety and depression, improved body image and sexuality, and improved self-esteem. And there are a number of publications and articles regarding supporting these findings. So are we jeopardizing the survival for cosmetics? The answer is no. Evidence shows equivalence in terms of disease outcome for breast conserving surgery followed by radiotherapy and mastectomy. There are various large RCTs which have found there is no significant difference in survival or risk of death over the 10 years. There was a question that maybe for the women who were 40 years or younger, for those women, breast conserving surgery would lead to recurrences. But there were meta-analyses that showed that mastectomy does not provide better overall survival compared to breast conserving surgery with whole breast radiotherapy in early breast cancer with women aged 40 years or younger. And these are the references. A number of articles are there. So at present, we can assume that we can comfortably and safely do mastectomy as well as breast conserving surgery for the women suffering from breast cancer. And failure to offer breast conservation to suitable and appropriate patients is now a medical legal issue. If a patient who fulfills the criteria for breast conserving surgery is treated by mastectomy, then the exact reasons should be recorded legally in the patient's notes. So patient selection is very important. So we have to be very cautious in selecting who will undergo mastectomy and who will undergo breast conserving surgeries. So this is the indication of mastectomy. This has been taken from National Clinical Guideline of Breast Cancer Management in Bangladesh. And the number one indication is patient choice. We cannot impose anything on patients. So an operable tumors more than 4 centimeters in diameter in average size breast. There is often various controversies about the exact size. Maybe in a small breast 4 centimeter, a 3 centimeter tumor may not be amenable for conservation, or even in a big breast, tumors more than 4 centimeter can also be amenable for breast conserving surgery. If there is operable masses in more than one quadrant of the breast, if there is any contraindication of radiotherapy, we cannot go for mastectomy. We can go for mastectomy. If the breast conserving surgery is failed, like there is local recurrence or there is positive margins after wide local excision where further local excision is not feasible, then we can go for mastectomy. Where breast conservation is unlikely to result in acceptable cosmetic outcome, that is larger tumor in small breast, then we can go for mastectomy. Central breast cancer is an indication for mastectomy. It is generally accepted that adequate margins are more difficult to achieve with central breast tumors and that central wide local excision may be associated with a relatively poor cosmetic outcome. However, in many cases, an adequate excision and good cosmetics can be achieved by a central wide local excision and oncoplastic techniques. And if there is local recurrence, we can go for mastectomy. And who are the candidates of breast conserving surgery? And this is also taken from the National Clinical Guideline. So number one, patient's choice. Operable tumors up to 4 centimeters in diameter in average size breast can go for breast conservation. Operable multifocal tumors restricted to a single breast quadrant can go for breast conservation. 2 or more small tumors in different quadrants of large-sized breast can go for breast conservation. If there should not be any contraindications of radiotherapy, contraindications to radiotherapy for breast conservation, larger tumors may be treated by breast conserving surgery when combined with oncoplastic procedures. Following neoadjuvant chemotherapy or neoadjuvant hormone therapy, specifically aimed at reducing tumor size. And these are the candidates for breast conserving surgery. And we have some common misconceptions about the contraindications. Number one misconception is age. We often fail to offer breast conservation options to the aged woman. Increased age is not a contraindication for breast conservation. Patients of all ages who fulfill the criteria for breast conserving surgery should be offered options. And now the women are very much cautious and they are very much well informed. So we should offer the options to the patients. This is one of our patients who was about 70 years of age, and she opted for breast conserving surgery, and she didn't want to go for mastectomy. And this is the day the stitch was, the dressing was removed. The second misconception we have that axillary status. Axillary lymph node involvement status must not influence surgery on the breast. Even N2 or N3 disease patients can safely undergo breast conserving surgery if the other criteria are fulfilled. This is one of our patients who was a 26-year married woman. She presented with palpable lymph nodes, and there was no palpable lesion on the breast. So from the lymph node biopsy it said that it was a ductal carcinoma, and we later by mammography an ultrasonogram we detected the lesion, and we excised the lesion with wire localization, and then we did the wide local excision, and this patient is post-operatively, and she was doing fine after the treatment was over. And molecular state of the disease is not also a contraindication. It will not influence the operative decision. Triple negative breast cancer patients can undergo breast conserving surgery. There are various studies. Low 5-year risk of local regional recurrence was achieved in a large group of women with T1 to N0 TNBC treated with multimodality therapy. Breast conserving surgery was equally effective as a mastectomy for local and distal control. And what about the patients who had bigger size tumors? Locally advanced breast cancer patients are treated with neoadjuvant chemotherapy or neoadjuvant endocrine therapy. Half of them undergo breast conserving surgery. Following neoadjuvant chemotherapy, 10 to 15% patients will have complete pathological response, and these patients will comfortably undergo breast conserving surgery by the wide excision of the original tumor site, and we will demarcate the original tumor site by putting tumor marker clip beforehand before starting the therapy. All patients undergoing neoadjuvant chemotherapy who might be candidates for subsequent breast conserving surgery should have a tumor marker placed before or early during the treatment. So these are the number of articles that advocate that BCS after neoadjuvant chemotherapy or neoadjuvant endocrine therapy is safe and feasible. So for doing breast conservation or doing wide local excision or lumpectomy, we have to be very much cautious about the margin status, because if the tumor remains in the margin, it will invite recurrence, and recurrence is the only thing that we do not want to have while treating breast cancer. And for oncological clearance, we should have a clear margin. In the first picture, we see this is a negative margin because the tumor is at the center of the specimen, and all around is a healthy normal tissue, and edges are clear of any tumor tissue. The second, this has positive margin here. Here the tumor, we have the excision margin is through the tumor. So if we leave it like this will lead to recurrence of the disease. So assessing the margin status is very important. And how will we assess the margin? We can do it by paraoperative frozen section that we are practicing in our institute. can do paraoperative specimen radiography. There are various novel techniques which are not in use yet, and we can of course do the routine histopathological examination. So before doing that, before going for breast conserving surgery, we should brief the patient about the possibility of the re-surgery or possibility of the margin being positive after surgery. So this is specimen orientation. Specimen should be oriented as soon as it is removed from the body. Here we can see that the surgery is going on, and a team member went on site to do the specimen orientation. And here we can see the specimen has been oriented. We can see a long thread tied here and a short thread tied here. And these are some protocols. We use long thread for lateral borders, short thread for superior border, and double thread for the deep border. So orientation of specimen is very important to assess the margin status. Okay. We should offer further surgery, that is re-excision or mastectomy, which is appropriate after breast conserving surgery, where invasive cancer and or DCIS is present at the radial margin. That is called tumor on ink, 0 millimeter. This is the latest from the NICE guideline. They have developed, recommended it in 2018. And before it was recommended that 1 millimeter clear margin was necessary. For women who have had breast conserving surgery where invasive cancer and or DCIS is present within 2 millimeter of, but not at the radial margins, that is greater than 2 millimeter or less than 2 millimeter, we can discuss the benefits and risks of further surgery, that is re-excision or mastectomy, to minimize the risk of local recurrence. We can take into account the women's preferences, comorbidities, tumor characteristics, and the potential use of radiotherapy. Now, the second concern, the first concern is of breast conserving surgery is having a clear margin, and the second, that is for the oncological clearance, and the second concern is the cosmesis. So the correction of defect or the closing of defect is very important, and so we must know the exact volume of tissue we have removed from the breast. But for doing that, we can do the specimen weight. We can take the specimen weight in the operation theater, and by that we can calculate that how much volume of tissue the patient had in her breast and how much has been removed, so we can deduct the percentage very easily. So if we remove from less than, this is taken from the a book from Dixon. If we can, there less than 5% volume is removed, then the cavity may be left open for the seroma to cover up. But for more than 5 centimeter, but 5%, but less than 10% of the tissue is lost, the tissue mobilization from the overlying skin, subcutaneous tissue, or underlying chest wall can be done. And if it is more than 10%, but less than 20%, mobilization of the breast plates can be done, and this can be done for the dense breast, not appropriate for the loose breast. And if there is more than 20% of the volume loss, we can do various oncoplastic procedures. The oncoplastic procedures are the procedures where oncological surgery is merged with the principles of plastic surgery, and we can do the volume displacement or volume replacement, and we need to have various special training in plastic surgery to do these oncoplastic procedures. Sometimes we may have tumors, or we may encounter cancers which are impalpable. Cancers, before becoming clinically evident, may be identified by imaging, that is mammography. Incidence of diagnosis of non-palpable tumor is increasing because of breast imaging techniques. So to remove the impalpable tumor, we have to know beforehand where the tumor exactly is. To know that, we can take the help of these wires. These are the wires. These wires are put before the surgery by the image guidance in the tumor, and the radiologist gives us the guidance at what distance the marker has been put, the depth and the distance from the entry point, and we can follow his direction and the marker, and we can excise the tumor. And first picture, we can see this is an ultrasonogram guidance wire has been introduced, and this is the mammographic picture after the wire has been introduced into the tumor to confirm the position. And these are two of our patients. We can see that wires are sticking out from her breast, from their breast. And these are the tumor excision is in progress. We can see the wire here. And this is the specimen after excision and orientation with wire in situ. We can see the wire orientation threads, and these are the wires here. We talked about placing the biomarkers just a few slides back when we were talking about giving neoadjuvant endocrine therapy, neoadjuvant therapy in locally advanced tumors. So before starting neoadjuvant therapy, we should put these type of biomarkers under the image guidance in the center of the tumor. And these markers are very small, like this size, very tiny. These are of various shapes, and we can see these shapes in the images in the mammographic pictures. And these will give us direction where the tumor actually was, if there is complete pathological response. So these are the principles we have talked about. We have been talking about the mastectomy and breast conserving surgery, and taking in account that we have all the facilities, we can do these practices here. But in practical situation, when we are doing surgeries in Bangladesh, there are various obstacles we face that are not actually written in any guidelines. The first of all, we encounter various tumors which are most of our tumors are larger in size. Most women present late with unfavorable tumor size, and many present with locally advanced breast cancer. And after counseling these patients, most of the time they do not want to go for breast conserving surgery after downsizing the tumor. Radiotherapy in a facility is a very big concern because there is limited facilities of radiotherapy. So there is usually a long queue with the patients after going breast conservation do not always get chance to go receive the radiotherapy in appropriate time. And it is extra burden, extra cost for the patients getting radiotherapy. And there is always a fear about any therapy among the patients, and they have various fear about the complications of radiotherapy. So they tend to avoid radiotherapy. So we usually do counseling that before a patient deciding if she will, before going for breast conserving surgery, we counsel about the radiotherapy, and if the patients agree that they can have radiotherapy, only then we proceed for breast conservation. There is a possibility of multiple procedures is also a big obstacle. There is a possibility of re-excision of margins. Although doing frozen section has minimized the chance of going in the theater for the second time for the re-excision of margins, but of course there is always a possibility of discordance of reports in the routine test. So there is also a possibility of later mastectomy if the margins are not favorable, and there may be a secondary axillary procedure may be needed. So possibility of when the patients hear that there is a possibility of multiple procedures, they usually go back. So longer treatment duration. Radiotherapy adds extra duration for treatment, and repeat surgery also lengthen the treatment. And most of our patients do not want to make their treatment procedure lengthy. As most of our treatment is center-based, it is Dhaka-based or tertiary center-based. So often it is very not very comfortable for not very easy for the patients to come to Dhaka and stay here for longer time and complete all her treatments. And there is always a fear of incomplete treatment. patients have a conception that cancer may be left behind. If the breast is left, the cancer will be left behind in the breast. And if the breast is left, the cancer may return. This fear in many a times inhibit a patient for choosing breast conserving surgery. Lack of knowledge, and this lack of knowledge is on the side of the patient and guardian. They haven't heard of preserving the breast in case there is cancer. So there is a lack of knowledge. There is a peer pressure. They talk to other patients. They talk to other family members, and every family, everyone in Bangladesh now know a patient who has a breast cancer, and so they are always advising. And most of the time, the patients hear that patient know that the other patients did have mastectomy, so they do not readily accept for having breast conserving in most of the cases, in many a times. Even the medical practitioner, they also lack the knowledge about the breast conservation. When we started breast conserving surgery back in 2017-18, many of our patients were returned back to us from the other institutes or from the outdoors to have their surgery completed. And many a times our patients were briefed that their surgery was inadequate. So the patients used to get confused when you listen these things of get this information from a doctor, and the patients are very easily confused. Poor referral system is a big problem.
Amia, sorry for interruption. If possible, please complete within 5 minutes.
Yeah, thank you. Most of our patients are confused about where to go because we do not have single center facilities. She comes to me, I advise her about the surgical part, and then I refer her to another department, and there is no smooth referral system between me and my other colleagues. And we lack a multidisciplinary multidisciplinary tumor board. So all patients should undergo a MDT meeting before starting a treatment. This is an international protocol, but we lack it very miserably. And of course, we do not have effective referral system. And cost is another thing patients are very concerned about, because the length of treatment, diagnosis expenses, procedural expenses, resurgery expenses, radiotherapy expenses, follow-up expenses, all adds up to the cost. And so since we do not have health insurance, these really becomes a burden for our patients. But there are rays of hope. The second picture, these used to be the picture of common breast cancers we used to get about 10 or 15 years back. But nowadays, because of the awareness and better imaging, we get tumors which are like these smaller sizes. So this is a good sign. Our patients are coming early. And we are also trying to overcome some of our lackings, like when we started wire-guided wide localization and excision, we did not have any wires. So we used the spinocane needles. You can see the spinocane needles sticking out, and the excision was very successful. It was done in January 2018. And this is one of our patients. This patient was a widow, a middle-aged widow. She worked as a cleaner in a hospital. She underwent breast conserving surgery, radiotherapy, chemotherapy, and now she is doing fine 3 years after surgery. This is another old woman. This woman was 68 years of age, and she was very happy with her breast conservation. And these are our other patients. This last patient, she was a 22 years newly married girl who had a 3.5 centimeter tumor. And after breast conservation, she is now pregnant and will be delivering next month. And this is another 33-year patient. We did wire-guided wide localization because she had an impulsible 1.75, I think 0.75 centimeter lump, and she was referred back from Bangalore. And we started sentinel lymph node biopsy, though we do not have any gamma active probes. We started to using blue dyes, and we started to use dyes which are used by the ophthalmologist, and we use those dyes, and these gives brilliant blue color of the sentinel node. And another good thing about another hope is that we now have a national clinical guideline of breast cancer management in Bangladesh that was published in February 2020 by Association of Breast Surgeons of Bangladesh, and all the fraternity surgery, surgical, oncological, and radiologists who are involved in the treatment of breast cancer. So the future of breast cancer treatment in Bangladesh is very bright. Thank you. Stay safe.
Thank you, Dr. Samia Mubin ma'am, for your beautiful informative presentation. Hello.
Yes, you continue, please.
It is worth mentioning that although oncoplastic breast surgery introduced in the world in early 90s, even after 30 years of its inception, it is practiced only in a few centers in Bangladesh. Our second topic is oncoplastic breast surgery future perspective, and the speaker is from the land of origin of reconstruction, renowned Indian breast surgeon Professor Diptendra Kesarkar from IPGMER and SSKM Hospital. He is founder of country's first dedicated breast service in 2000 at internationally recognized SSKM Hospital, former president of Association of Breast Surgeons of India, and presently tutor examiner with the Royal College of Surgeons of Edinburgh. He has 71 research papers. Dr. Professor Diptendra Kesarkar. Sir.
Thank you. Thank you. And now, a warm good evening from Kolkata. Incidentally, এটা প্রথমে বলে নেওয়া ভালো যে the last physical conference that I had attended was in Bangladesh, as Professor Mubin was telling, that was in Army Club in Dhaka, and that was between 26th and 27th of February. And I was honored to be part of the publication of the first guideline of breast cancer treatment in Bangladesh. And I was open in discussing and commenting that Bangladesh could publish their first possible breast cancer guideline and India is unable to do so. So with that last wonderful and romantic ideas and nostalgic ideas of the last conference that I had and the wonderful shopping I had done for my wife, thanks to Dr. Mubin's advice to go to certain shopping malls. And so I always feel that Epar Bangla remains the same tradition and emotion for me as is this part of Bengal. And today I would be talking on something which goes back to 132 years. And most of you might have seen this movie called The Good, the Bad, and the Ugly, which was a movie from the Hollywood starring Clint Eastwood. And Clint Eastwood was the good. And what I'm going to do in next 20 odd minutes is to take you through in a reverse way from the ugly to the bad to the good. And that's the journey which Professor Mubin was commenting upon from the days of William Halsted. And therefore, I'd be able to tell you the significance of oncoplastic surgery. And I am going to talk the perspective of Bengal, Bangladesh, as well as West Bengal, and what innovations can we do from our part, and not really a global view of what an oncoplasty would mean in NHS or in the United States of America. And I have divided my talk into 5 chapters. The first chapter would be the prelogue, which deals with how things shift from Halsted to Varanasi. The second chapter is how at present breast conservation surgery becomes the standard of care. The third chapter would deal with oncoplastic surgery, which is definitely the search for excellence. Fourth chapter will be oncoplastic surgery and beyond. What sort of volume replacement surgeries we can provide. And finally, I will come back to the basics, which we should not forget even when we are doing the advanced surgeries that we would be talking about. Coming to the prelogue, and of course, all of you have been already well versed with what the Holstedian concept of mastectomy meant. And therefore, in the next 70 years, it became the standard of care. And there was no confusion, the fact that in the absence of adjuvants and neoadjuvant, it had saved life. And the survival was 66% without any other form of adjuvant therapy, provided the patients were detected early. And the first possible oncoplastic surgery that was performed was preservation of the pectoralis major muscle, giving rise to the Patty's procedure and its variation. But the winds of conservatism was in the air from the 1970s. And it was because this gentleman, Bernard Fisher, who first put forward the idea that breast cancer is a systemic disease, and what more or little that you do on the breast tumor is unlikely to affect the long-term outcome. And therefore, breast conservation surgery came into vogue. And today, as Professor Mubin rightly said, we must be able to document why in a particular sort of patient we are not doing a breast conservation surgery, which was reversed a decade back. We would write why we are going to perform a breast conservation surgery. And Professor Mubin has also told you about QUAT and TART. But this is the concept that is coming up, CTART. That means we were doing a complex oncoplastic surgery, the picture of which I will show. But thanks to the wonderful response with neoadjuvant therapy, the complexities are gradually diminishing, and we would be able to offer patients with simpler oncoplastic procedures. And the fourth part is we are able to deliver in locally advanced breast cancer, unless they are hugely fungating lesions or with inflammatory cancers, we'd be able to provide them with neoadjuvant chemotherapy, downsize it to as small as in millimeters, and often it might actually vanish, and offer them breast conservation therapy. And there are evidence to suggest that it is definitely not inferior to what we used to call as the radical mastectomies. And these are the basic principles, because before we go into oncoplasty, just for trainees, you need to understand that this is the particular prototype type of incision that we are going to place in a patient where we are planning for a simple breast conservation surgery. But if it is in the lower quadrant, I'd rather place an incision like this, because that gives a more aesthetic outcome in terms of breast conservation, and that also helps us in doing certain oncoplastic procedures. And in most of the circumstances, coupling it with a simple or a complex oncoplastic surgery, you are going to get results which are as good as this. And therefore, voila, you can shout that I have been able to deliver or give back the lady the breast which she had before she had breast cancer. Quite often, though, we might have smaller variations like the ones that you see in the picture. And in these circumstances, if the lady is not very unhappy, we would leave it as such. And if she is really unhappy, we might add a bit of reduction on the opposite side. But in certain circumstances, it might end up in this. And while the patient is lying down, we might end up in over-excising. And this is one of my residents who did an oncoplastic surgery. And he did a breast conservation surgery. When the patient sat up in the ward, it was disaster. And for these patients, you need some sort of oncoplastic procedures. And that would mean either correct the affected breast by some sort of remodeling of the breast, or in certain circumstances, depending on the patient's choice, reduce the opposite side. And therefore, we go into the third core area, which is the point of our discussion today, oncoplastic surgery, the search for excellence. And what are the key questions? Now, this is a Western definition. It defines that any surgical procedure in breast cancer that aims to re-establish the body's symmetry and thus play a significant role in women's physical, emotional, psychological recovery from breast cancer is an oncoplastic surgery. I understand this is good enough, but towards the end of my lecture, in last 2 to 3 minutes, I will show you why this definition needs a change in our perspective, particularly in the perspective of Bangladesh and India and Southeastern countries for that matter. So again, trainees must understand that today we must be able to determine the breast volume, and that is an universal language. Now, this is how it is calculated. Trainees, please note that the first is called the band size. That is the measurement at the inframammary crease. The second one is called the bust size. That is the breast circumference or the chest wall circumference at the level of the neck. And then you subtract between the two. If it is 1 inch, then it's cup A. If it is 2 inch, then it is cup B, like forth and like so. So therefore, in today's description, if I call up my friend, somebody in UK, and if I describe it is a 34C breast, that means he will understand that the bust size is 34 and the difference between the bust and the inframammary crease is around 3 inches, and therefore he would be able to plan a particular type of oncoplastic surgery. And this is what is the universal description of breast today. And based on this, Krishna Cloud classified is at type 1, type 2, and type 3. Let's make it very simple. It depends whether the defect is small, whether the defect is moderate, and the defect is large. Again, it depends, as I see, on the size of the breast. So a small defect in a large breast is nothing, whereas a small defect or a moderate defect in a small volume breast can be a big thing where an oncoplastic procedure is required. So we need to understand the tumor size and the breast, and therefore put it on a ratio to understand whether the lady will need an oncoplastic procedure or not. Another important point which Professor Mubin has forward, I'm going to re-emphasize is in locally advanced breast cancer, we give neoadjuvant chemotherapy. Now, whether we give neoadjuvant chemotherapy and operate, or we operate and we give adjuvant therapy, nothing changes. The overall survival remains the same. But one fact that evolves is that the breast conservation surgery rate incidences increase. And therefore, if we give neoadjuvant therapy in locally advanced breast cancer, and even a small subset of early breast cancer in a small volume breast, we are likely to improve the aesthetic outcome of treatment. So the third tool we must remember, apart from the size of the breast, the size of the tumor, is whether this patient would merit neoadjuvant chemotherapy so as to reduce the size of the tumor and therefore to offer breast conservation surgery after that. And therefore, many of my friends, they do not stick to the traditional definition of centimeters. And if they find it's a large lesion, more than 3 centimeters, they would put in a core biopsy and put in a marker, put the patient on neoadjuvant chemotherapy, and as Dr. Mubin was showing the pictures, you can put in a marker and wire-guided excision. So a 4 centimeter tumor at the time when you are operating after neoadjuvant therapy can be 7 millimeter, and therefore you don't require complex forms of reconstructions. So if the volume loss is less than 10%, more than 10 and within 20%, you require a small sort of mobilization of the breast and get away with that. But if it's bigger volume loss, then you require some complex forms. These are the cafeteria choices that you have. And I will select some of the choices which I always felt is quite important. Now look at the basic principles. Again, trainees try to understand. Most of the senior surgeons would know that. Now this is a breast with an acceptable small tumor located at particular size. So what you're going to do, you're going to excise it. Now after excision, there will be a gap. And this gap needs to be filled up by mobilizing the breast from the above and the mobilizing breast from the lower, or mobilizing breast from the lateral side and from the medial side. And therefore, after you have apposed it, then you need to reunite the breast at 3 levels, one at the base level, the second as the mid level, and third in the subcutaneous level, so that you get a conformation of the breast which is as good as what the lady had before the surgery. And so this is the principle of mobilization of breastplate and reapposing it so that it becomes cosmetically acceptable. So what are the complex oncoplastic surgeries? Now, as Dr. Mubin was telling, that we do have a relative contraindication when it's come to a nipple areola complex lesion. Now, this is an example of a flap called Grisoti flap. Now, what we do is we excise this part and then we keep this and completely de-epithelialize this and create a tunnel to take it up inside this. And this is called a Grisoti flap, which gives the lady an appearance of a nipple areola complex. And we can create the nipple later on. I will show you the technique in a few slides after. Now, this is a new flap that has come. And when I mean new, it has come in last 3-4 years. And it was started by one of my friend called Amit Agarwal and Rishi Parameswar, and the Cambridge group is advocating this called LICAP. Now, again, remember the anatomy that that the lateral thoracic vessels, they pass like this. And the intercostal, one of the intercostals, they come out through this. And most of you, when you are doing a mastectomy, you would encounter these vessels bleeding when you are trying to enter into the axilla. So if you can keep these vessels and rotate this, and this is a case where after a previous history of breast conservation surgery was done, and the patient had a recurrence outer quadrant, we mobilized the LICAP flap and reunited it, giving it a wonderful contour. Now, this is another very handy oncoplastic procedure that you have. Now, it can be in a tumor which is situated here, or here, or here, or here, say approximately 2 to 3 centimeters away from the nipple areola complex. So what we will do is we are going to make 2 parallel circles and then de-epithelialize the whole thing. So once we de-epithelialize the whole thing, the nipple blood supply remain intact. So in this particular case, the tumor was here. Then you make a tunnel here and take the tumor out. And after you have taken the tumor out, you can reappose it the way it looks. And after say around 6 weeks, no scar is there in the breast except a nipple areola complex with a firm border around it. Now, when it comes to the upper medial quadrant of the breast, that is a very challenging area to target, because creating the medial fold is beyond the capacity of most of the surgeons. And if you try to put in a scar directly in that area, most ladies will not like that scar popping out of the medial edge of the blouse. And so therefore, this technique, which is called a bat wing mastopexy, or even you can also choose a round block in certain cases, is an ideal technique to approach a medial quadrant lesion and take it out without actually destroying the medial fold, at the same time not creating any ugly scar in the outer quadrant, inner quadrant of the breast. Now, for the lower quadrant, as I said, these are examples of inferior quadrant mammoplasty. And this, as I was saying, if you make an incision, you can excise a large amount of tissue and end up doing a perfect reunited breast with wonderful cosmetic outcome. This is a procedure that we started almost 1.5 decades back. And at that time, I was experimenting with reduction mastopexy. I had just learned it from Manchester. I was trying to experiment it, and later on, it became a standard of care in the West. And what we would do is, I had applied initially. So what we would do is, now this is the nipple areola complex, and again, this part is de-epithelialized, so the whole blood supply to the neck remains. Now, after we have excised it, we are going to bring these 2 ends in the midline and join it up as a T shape. And so the lady is going to have a large volume of tumor excised, maintaining the wonderful contour. And today, after we have neoadjuvant therapies, we do not require these complex procedures. Now, this is an example I have put for a large phylloid tumor where we had done an inferior quadrant mastopexy, and see the results. It would look like a perfect symmetrized breast, even after you are taken out 10 centimeter into 10 centimeter breast tissue. The symmetrization is perfect. And therefore, it has become a gold standard for these lesions. But as I said, if you are applying neoadjuvant therapies, you don't require these complex procedures any further. Now, this is another flap that we innovated only just before the onset of the pandemic. Now, look at this. This patient had needed a breast conservation. She was hell-bent on doing a breast conservation. We had given neoadjuvant therapy. She had a multifocal lesion in the lower breast. The skin was tethered. And therefore, we had to innovate. And we used this flap where we took this is called a vertical rectal abdominis myocutaneous flap. And if you can match the concavo-convex surface of around the umbilicus well, then you can actually create a perfect looking breast as you see in this particular picture. So as I said, even if there is skin involvement, that is not a contraindication for a breast conservation if you can add some amount of oncoplasty to it. And this is the perspective that we are talking about for EPAR Bangla as well as OPAR Bangla, that we can innovate in delivering breast conservation and oncoplasty even in locally advanced breast cancer. But there will be large tumors which will fail neoadjuvant therapy. There will be multicentric lesions. There will be lesions with gross skin involvement. There will be lesions we have patchy response in neoadjuvant therapy. And therefore we come to the next line. Now, this is the good person being challenged by the ugly person. Does that mean it is the end of the world? The answer to the question is we would move forward. And I would actually include volume replacement therapy as an extension of oncoplastic surgery, though of course the West would argue including a volume replacement therapy. They would still continue OPS as a volume displacement therapy, but in our perspective, would like to include this. Now, this is a classical case of 42-year lady who had undergone 6 cycles of neoadjuvant therapy. It's a 34B breast, pre-NSCT, 4 centimeter, post-NSCT, clinically impalpable. But look at the MRI, the response is patchy. And therefore, we had to do a modified radical mastectomy because it's a patchy response, and a primary glandular replacement therapy was advocated. This is another innovation. So those of you who are planning to start these procedures, you can use this. Now look what I have done. I have done a mastectomy by a lateral crease incision in the axilla, through which I have taken out all the axillary lymph nodes. I have taken out the whole breast. I could have used a simple thing called a prosthesis. But instead, what I have done is I have taken out the latissimus dorsi muscle in large bulk and could just put it into the breast, and look at the result. It is just fantastic. So that is the innovation that I'm talking about for our part of the globe, where prosthesis most of the patients cannot afford, or you may not be able to get prosthesis in most circumstances, but you can use an autologous myocutaneous latissimus dorsi flap with a mastectomy done by an axillary crease and refill the breast. So therefore, this flap, latissimus dorsi, is a versatile flap. And therefore, those who are beginning, they must understand the basic anatomy. It is a muscle which has dual supply, the thoracodorsal pedicle, as well as blood supply from the lumbar vessels. And these are the perforators that you see after the descending branch comes, and they give rise to 3 perforators. And therefore, the advantage is the perforators go beyond the muscle, and therefore you can actually stretch the fat inclusion beyond the muscle to a large extent, and therefore you can create a large robust flap. And therefore, in spite of the fact that it was losing its popularity, it came back with modifications called fluid release, where used to take large amount of fat. And today we have this technique which is called the delays modification, where we take fat above, fat beneath, fat on this side and fat on that side. And therefore, as I said, you can create a large bulk of latissimus dorsi and you can use it. And where can you use it? And therefore, I call it the magic of thoracodorsal pedicle. Why it is a magic? Because this is a very robust flap. It has got a blood supply, it goes down, and even if you cut the main branch accidentally, the branch which comes from the chest wall is a good enough branch to give rise and continue with the vascularity of the pedicle. And this is an example that I am talking about. Forget the Western data of not doing, and they would not offer anything to this lady. They would just close the door on her. And in this group of patients, you can add latissimus dorsi mycutaneous flap. Don't add bulk, but at the same time, you can start some form of radiation as early as possible. Now, this is a very bad recurrence in the axilla. What we can do is we can rotate after a wide excision, we can rotate the latissimus dorsi mycutaneous flap, and after even the vessels, the artery and the vein is bare, you can use it to cover it. So this is an example of how the pedicle can be covered. I mean, the axillary neurovascular bundle can be covered with latissimus dorsi muscle. The third use is, now look at this lady, she had a larger volume loss, didn't have much response with neoadjuvant therapy. And in this patient, we had added the latissimus dorsi muscle as a filler, and therefore we could use it. We can also use it as supplementation with prosthesis. I have kept prosthesis out of the discussion because that's not the easy choice available in this part of the globe. We can use latissimus dorsi as an autologous flap. That was what I was suggesting. Look at this, the volume match is very close, if not the best, but it's very close if you can utilize the muscle and the fat as a whole in the back. And therefore, this is another example of in a small volume breast. The problem in this subcontinent is that our ladies do not have much back exercise, so the muscle is thin. However, if you use the fat that is available behind, you can create or decreate a breast to a certain extent in certain circumstances, though of course my plastic surgery colleagues would prefer a DF so that they want to avoid the lower part morbidity. But if I am doing it, I would go for a pedicle tram in most circumstances. As I said, as I promised, the nipple can be created wonderfully. This is a very simple technique called a trifoliate technique, where you actually elevate it like this and fold these two parts one upon other, and you can create a wonderful mount of nipple. And then you can tattoo the areola, or you can put in skin graft in the areola to create it. But creating the nipple is a challenge, and you can create it under local anesthesia by a very simple technique as this. So the debate finally is, which one is better, the immediate or the delayed? I mean, there is no argument today that, in spite of the fact that many plastic surgeons would argue that it is time consuming, it is easy to deal, positive margins, and it's a visible defect. You get me back and I'm going to give you back a fantastic breast. The verdict is out. Immediate oncoplastic surgery is the standard of care. Nobody would like to have two surgeries. Nobody would like to have a surgery done on a radiated breast, and therefore oncoplastic surgery immediate is the standard of care. Is it oncologically safe? The answer to the question is yes. There is adequate level 1 evidence to suggest that it is absolutely oncologically safe. Rather, it increases the safety. With the traditional form of breast conservation, you always tend to be more conservative. But if you have the oncoplastic tools in your hand, you can go for a wider excision, and therefore the chances of margin positivity reduces. Finally, we can we stretch our limits? Now, this is the famous final scene in the movie, where three of them are standing and they are going to go for a gun duel. And the question is, can we stretch our limits? Now, these are examples which even in small peripheral setup you can do. Now, look at this. There are multiple fungating lesions in the breast. And what you can do is you can mobilize the whole abdominal flap. We call it a medial based thoracoabdominal flap to cover it. This is also an oncoplastic surgery for poor patient who have come to you with a fungating breast. Now look at this. This is a local recurrence. You could have added a very complex procedure. You can just mobilize the medial flap now and can end up in doing a wonderful thoracoabdominal flap, which is lateral based. So it can be a medial based or it can be a lateral based. And this works wonderful in terms of palliation, giving back the patient some quality of life, which the patient was losing because of the fungation. We can use the pectoralis major muscle. This is again a patient in whom there was fungation in the axilla. So we rotated the pectoralis major muscle and covered up the vessel. We started we would always argue that this is the end of the tunnel. Now look at this. We have done now around 7 or 8 of them. This is a classical sarcoma which presented to us with fungation in the chest wall. It was the end of the road for this patient. But we evaluated the patient. We found that there was no evidence of metastasis and there was isolated 2 rib involvement. So this is the picture where I am resecting not only the whole of the chest wall, but part of the ribs as well as part of the lungs. And then I would reinforce it with a simple polypropylene mesh. And over that, I am adding a latissimus dorsi and mycutaneous flap. This patient lived for 19 months and the patient had a good quality of life, finally dying because of metastasis in the lung without any evidence of local recurrence. And today we have more sophisticated mesh as well, and therefore the chances of mesh-induced pneumonitis have also reduced. So again, as I would reinforce, that chest wall reconstruction should be a very important component of oncoplasty in this part of the globe, which is unthinkable in the West. This was our publication, which goes back to 2011. And believe me, at that time, 72% of our work were based on inoperable and borderline operable locally advanced breast cancer. So the statement that it is only for early breast cancer holds true for a hospital in the NHS, but that doesn't hold true for a hospital in, we call it the PG hospital in Calcutta, and you call it the PG hospital in Dhaka, and it has got immense scope in these patients as well. So coming final chapter is back to the basics. I would like to come to a very basic thing for all trainees. Now, marking of the cavity is extremely important in breast conservation surgery. You have seen the pictures where actually the upper medial quadrant can go into the lower outer quadrant because you are mobilizing the whole breast. And therefore, after you have excised the tumor, the wall has to be clipped. Now mark my words, trainees, the wall has to be clipped. Do not, for God's sake, clip the pectoralis major, because pectoralis major is a static structure and the breast is going to move away. The cavity is going to move away. You are doing an oncoplastic surgery. So later on, when the radiation is being given, what happens? You are radiating the zone on the pectoralis major, but the cavity has actually shifted. So the boost was supposed to be in the cavity, which has shifted. So marking of the wall is important and not the depth of the pectoralis major muscle. The second important thing, which Professor Mubin has rightly pointed out, you must be able to mark and orient the specimen in a proper way, because in case even after doing a frozen section it comes out to be positive, you must know exactly which part to be taken out. Because it's an oncoplastic surgery, you must have a focused excision of the superior margin and do not actually go into a mastectomy after the first positivity. What is adequate margin? 1 centimeter macroscopic negative ink margin. The in-between statement has disappeared now. So we'd be happy if there is no cancer cell on the inked margin. So these are the indications for re-excision. Gross positive margin, yes, you must reconstruction. You must re-excise. Multifocal microscopic positive, yes. Gross extratumoral DCIS, yes. But in today's era, the robust evidence suggests that if there is unifocal single area of microscopic positivity, that is not an indication for re-excision. You can continue with the radiation oncologist, provided you have marked the cavity in a proper way. Coming finally to the epilogue, I must state that breast conservation therapy is the standard of care in breast cancer management today. Mastectomy is an exception. In spite of the fact that we deal with large number of locally advanced breast cancer, I still would make this statement absolutely from the same spectrum. Oncoplastic surgery is an integral part of breast surgery. If you need some sort of mobilization, it has to be done and it has to be learned. Immediate oncoplastic surgery is better than delayed oncoplastic surgery. It is safe And final statement to be that oncoplastic surgery is in locally advanced breast cancer is our problem. Don't wait, for God's sake, from the West to teach us how to go ahead with reconstruction in a locally advanced breast cancer. We need to innovate at every step. And we are the group of people who are going to show the world how we can manage locally advanced breast cancer with oncoplastic surgery and do a breast conservation therapy. Just because the Western data would not justify this procedure, it is not a good enough reason, because in the next 2.5 decades, the Western world would not be able to give you enough data of doing an oncoplasty in a locally advanced breast cancer. So the case rests on us, my Lord. I finally end those who have been with us for the last 1 decade, and I have got so many friends in Bangladesh. And we did a conference in 2016 where I actually was honored to have almost 20 guests coming from Bangladesh. And that conference was called the EPAR Bangla OPAR Bangla Conference of survivors. And we had survivors coming from Dhaka to Calcutta. And we are planning to do this year, but it won't be possible. But next year, I'm sure we are going to have that. And this talk is therefore dedicated for the survivors and the winners of this part of the globe, which we call Disha for Cancer. And this was the last conference we had last year. We didn't have one this year, but I'm sure it is the patient who speaks for our surgery. It is not the data which speaks for us. So salute to the winners, and once again, thanks to the Surgical Society of Bangladesh, and particularly to Professor Bhuiya and Professor Shahidullah, who has given me the honor and privilege to be part of this wonderful academic meet. Thank you very much.
Thanks, Professor Jitendra Keshwarkar sir, for your thorough dynamic presentation, and salute to the cancer survivor. Really, it was a spellbound presentation. Our next topic is on tumor board. Multidisciplinary tumor approach, breast cancer management has become increasingly complex, requiring comprehensive assessment and review of multiple issues. To provide optimal care to patients, MDT approach is mandatory. And this topic is going to be presented by Dr. Shakir Ahmed, Assistant Professor, Department of Surgery, Chittagong Medical College, Chattogram.
Honorable Chairperson, my respected teachers and dear colleagues, Assalamu alaikum. At the beginning of my speech, I want to give thanks to the Society of Surgeons of Bangladesh for giving me the chance to speak in front of such an august gathering. I will talk about multidisciplinary approach of breast cancer management, or tumor board. And on introduction, the complexity of cancer diagnosis and treatment, together with the increasing need for individualized patient care, has led to the organization of multidisciplinary team or tumor boards or cancer conferences. The optimal management of breast cancer patients require the expertise of specialists from different disciplines. This has led to the evolution of multidisciplinary teams, allowing all key professionals to jointly discuss individual patients and to contribute independently to clinical decisions. If I want to say about the background, based on William S. Halstead's theory that breast cancer is a strictly local disease that spreads by orderly progression and is thus curable by radical surgery, breast cancer used to be managed almost exclusively by surgeons before the mid-1970s. The work of Bernard Fisher and Edwin Fisher in the 1960s led to the development of an alternative hypothesis that breast cancer is a systemic disease and may have spread of undetectable tumor cells at the time of diagnosis. This contributed to a paradigm shift in breast cancer management, and systemic therapy began to be used to treat patients with early stage disease. As a result of evolution and reinforcement of breast cancer diagnosis, staging, and management, the treatment algorithm gradually became more complex. This complex management requires the expertise of a wide range of specialists, and effective communication among them is crucial for optimal treatment strategy. The effort to facilitate such communication has led to the evolution of multidisciplinary team. According to the UK Department of Healthcare Disciplines, MDT is defined as a group of people of different healthcare disciplines which meets together at a given time, whether physically in one place or by video or teleconferencing, to discuss a given patient, and who are each able to contribute independently to the diagnostic and treatment decisions about the patient. So the benefits are, the MDT meetings have become an integral part of cancer management in many countries worldwide because it provides consistent, continuous, coordinated, and cost-effective care to the patient. The decisions made by the MDT are more likely to conform to evidence-based guidelines than those made by individual clinicians, and it increases patient satisfaction. There are different models of MDTs. I'm not going into details. The barriers are excessive caseload, low attendance at meeting, lack of leadership, poor communication, role ambiguity, failure to consider patients' holistic needs. The breast cancer MDTs, here the core members are the surgeon, radiologist, histopathologist, oncologist, and also breast care nurse and MDT coordinator. And the extended members include oncoplastic breast surgeon, data management personnel, clinical psychologist, and palliative care team. In this era of personalized medicine, there is a clear need for improvement in the MDT functioning worldwide. In the context of growing cancer incidence in Bangladesh, we badly need MDTs in management of breast cancer in our country. And multiple studies have shown that there is high satisfaction from working in MDTs that lead to better clinical decisions, evidence-based practice, improved quality of treatment, and patient satisfaction. These are some references. I'm not going in details. So now I like to discuss our cases with the tumor boards. And today our tumor board consists of a surgeon, radiologist, pathologist, and oncologist. So here our first case is Mrs. X, 42 years, young premenopausal lady, mother of 3 children with history of breastfeeding and oral contraceptive pill use. She is otherwise healthy. She has positive family history, and her sister was diagnosed as breast cancer patient at the age of 40. And she came with lump in her right breast for 2 days. And there was 2 into 1.5 centimeter mobile lump in upper outer quadrant. There was no palpable axillary lymph node, and right breast was normal. So now I like to request our honorable professor, Professor Sanawar Hussain sir, to please comment on how we will proceed with this patient for diagnosis. Sanwar sir, please. Can you hear me, sir? Sanwar sir, please. Saira, can you help me?
Okay, Appa, I'm checking the participants list. I'm looking for that.
Hello, Sanwar sir, are you here? Sorry. I want to ask Shahin Bhai, can you help me please?
Hello.
Yes. Shahin Bhai, is Sanwar sir here?
Sanwar তো ছিল মানে তুমি চুজ করো না
Okay, okay, then I can request our other professors. I can see there are so many legendary professors here. So can I ask Professor M.A. Mujid sir to discuss about this case, how to proceed to diagnosis?
Yes, I think in the first place, this patient should be discussed in a multidisciplinary team. But from the history, as you have mentioned, before you decide on the type of surgery you are going to offer to this patient, I think her genetic studies should be considered. She has got a family history of breast cancer. So I think one should consider doing BRC gene studies. And then we can decide on the next course of management.
Yes, sir. Of course, we should do, but in our perspective, actually, we cannot do it in all our government hospitals. I think it may be possible in very few institutions of our country, like BSMMU or some big hospitals in Dhaka. But in most of these institutions of Bangladesh, I think it's not that much easy.
Yes,
But it should be done.
Yes. And the other thing is this, more important thing is this, you have to do a core biopsy of the lump.
Yes.
Have you done any core biopsy of the
Yes.
lump?
Yes.
And let us know about the biopsy report and the
Yes.
hormone receptor status.
Yes.
That is ER, PR, and HER2 receptor status plus the biopsy
Yes.
report will give us some idea as to how to proceed.
Yes. Yes, sir. Sir, before showing the core biopsy report, can I show the ultrasonography and mammography of this patient?
Yeah, yes.
Why is this not connected, Shahin?
Yes, sir. Now connected, sir.
Oh, এতক্ষণ যাবত তোমাকে কানেক্ট করার আমি চেষ্টা করছিলাম। So, should I continue upon this?
Yes,
the
sir.
Shakira's picture or this others?
Yes, sir.
Shakira has given
sir.
a good data. So this is you see, while it is a conference with all the seniors and also the juniors and some of the trainees and the students are also listening to this. It is a clear picture of this breast tumor. The first approach should be in the line of the triple assessment. The data has been given. The imaging should be the first one. Then comes after it has been imaged, it will go for the cytological study, either a FNSC or a true-cut biopsy. That true-cut biopsy gives a better option because that not only confirms the diagnosis but also gives the receptor status and also a guideline which line of treatment should be appropriate. And that's why it will go there, and the team in conjunction with the others will decide which type of approach they will make for the management of this case. As Professor Mujid Saib was talking, the BRC study is an advanced study, not easily available in many of the centers. But before that, we can proceed. We can keep the BRC study for the future briefing of this patient and also the future management. So we start with the very simple one. The basic one is the triple assessment, and then that will give the diagnosis and also we can proceed.
Yes.
Thank you.
Yes, sir. Can I show the ultrasonography report, sir?
Yeah.
This is the picture of the ultrasonography.
Mhm.
In this regard, can I request Professor Subhash Majumdar, can you please describe this ultrasonography for us, and if you have any comment?
Yes, thank you, Dr. Shakira. I would like to thanks to all seniors engineers to give me the opportunity to attend here. This case particularly, as the patient about 42 years old, so appropriate investigation, first investigation should be the mammography. As
Yes,
because
we have done it. I will show
yes.
you later.
Yes, okay. First should be done the mammography to see the margins, whether it is regular or irregular margin or lobulated margin, to see the calcifications, macrocalcification, and the architectural distortion present or not. At the same time, we can see the axillary lymph node in the mammography also. This ultrasound is very easy to actually diagnose. This mass is a malignant and diagnosed as a malignant mass, as because this margins of the mass is the irregular margin and lobulated margin, and this margin, this tumor is vertically the height is vertical height is more than the transverse height, and sometimes there is a acoustic shadowing due to that microcalcifications in the mass. So in these types of tumor, the patients also have the axillary lymph nodes. So easily we can diagnose these types of lump as a malignant mass.
In this
After
regard, can I ask one question, that in case of breast cancer patients, should I do only the mammography or both ultrasonography and mammography?
No, actually, both, as because mammography and ultrasound is very easily available in instruments and devices in our country. So we go for the both mammography and ultrasound, as because we may miss in the ultrasound, particularly small lesions, as because in the large breast, we can miss the small lesion. So particularly after the age of the 40, if we think the breast is fatty, and fatty breast is very good for the mammography. We can easily diagnose any small mass, even speculated mass, deeply seated mass in the mammography with calcifications.
Yes, and also for the axilla, I think for the axilla, ultrasonography is very good.
Ultrasound also good, but we can also diagnose the lymph nodes in the axilla by the mammography also.
Okay.
So both
will
are very important.
I show the mammography now?
Yeah.
This is the ultrasound report. This is the mammography.
Yes. This mammography in our country, actually, these are the film and screening mammography. These are not the actually tomosynthesis. Only two film. Only this is the amylo and CC views of the simple screening mammography. So it is the sensitivity of this mammogram is not up to the level of the tomosynthesis. In our country, there are few centers also have the tomosynthesis, but they are not using it. They are giving only two films. So this film, actually, if we look for the film, there is no obvious lesions. And if we do not magnify these images, even we cannot find out the macrocalcifications in this in this mammography. So, and overlying skins are very clear, and subcutaneous tissue is normal, no speculated mass lesions over here, and no clear, actually, in this picture, there is no clear mass in this picture, only normal sized axillary lymph nodes. So after we should do the tomosynthesis or magnify this mass for actually comment of this mammogram. There is no clear-cut speculative lesions, but that in the retroareolar regions, there is about is a small speculative lesions so far, and I can see, but
Yeah,
I cannot see. I cannot see this clearly because it is the non-magnified images of the tooth images. Okay.
Yeah, this is the normal breast, and this is the report of the
as because of this is the screening mammography, so tomosynthesis is essential for the diagnosis of the actually these types of lesions. This is the single field mammography. That's
thanks. Now, as Honorable Professor Moji sir has mentioned, this is the core biopsy of this patient. This is the microscopic view. And so in this regard, I will request Professor Nasir, Tariq Al Nasir, if you comment on this picture, please.
সাগরা সরি তারেক আল নাসির স্যার স্যার একটু প্রবলেম হতে স্যার একটু লিভ করছে আমরা চুজ করব কুইকলি
Okay, this is the so we can see the report, and this is the invasive ductal carcinoma grade 2. Yes. So we can say the clinical staging here is T1 N1 M0. That is stage 1B according to clinical prognostic staging of AJCC cancer staging. And so may I now request Honorable Professor Sanwar sir, if he comment on the treatment plan of this patient.
Am I connected?
Yes, sir. Yes.
Do you listen to it?
Yes, sir. You're connected.
Sakra?
Yes, sir. Yes, sir. I can hear you.
What is the diagnosis?
It's invasive ductal carcinoma.
Yeah, this is
and
no
the
problem.
staging is
what is the stage?
Stage 1B. The T1 N1 M0.
Yes. So depending on the size of this tumor, what is the location?
Upper outer quadrant.
Upper and outer quadrant. Yes. Today's session favors this conservative breast surgery, and this oncoplastic assent is also there. Definitely, we would go for an acceptable cosmetic surgery for this patient, but at the same time, this should be a curative resection with a wide local margin, and the axillary sampling will be the part of this operation, and go for a frozen section to see these margins, both the superficial and the deep margins and these lateral margins all together. Then the receptor study will guide what type of adjuvant will be required for this type of patient.
Yes, sir. Thank you. Sir, what about the, as Moji sir already has mentioned, about the genetic counseling and also the screening for contralateral breast or risk reduction measures, as she has positive family history, whether we will talk about contralateral mastectomy or ovarian suppression or something.
No, not at this stage. When you find out these BRCA results and the treatment will proceed, it is better to remember, whenever you examine a breast tumor, as you see, it's a usual practice that you examine the tumor first. But my recommendation is that you should examine the contralateral breast first, and then you proceed with the very in details with the affected breast. So definitely it is a routine, and we must not forget that we have examined the contralateral breast. For the future counseling and the future planning about the genetic predisposition, definitely it comes after the treatment. And it is in the follow-up, after the initial briefing, in each follow-up, it should be remembered, definitely.
Yes, sir. Yes. So
And nowadays, you see, if you remember, the paradigm shift in the breast cancer in its treatment and also in the prognosis has come up around the 1970. It is not due to the surgery only. It is not the surgery. It is the invent of this chemotherapeutic agent and its efficacy and the judicial use. And today's, you see, the prognosis of the breast cancer and this cure is not dependent only the surgery, but it is more upon the I place more, and it is more due to this chemotherapy. So we should have there rather than this.
yes.
Others. Thank you.
But what we have offered her is modified radical mastectomy, right side, with level 2 axillary dissection. And this is her histopathology report. It's also ductal invasive carcinoma. And we also did the receptor status, and it was ER negative, PR negative, and HER2 was also equivocal.
So you should label it as a TNBC.
Yes,
triple negative.
triple negative. Yes.
Yeah.
Triple.
Even if you remember, or if you have got a little idea about this, nowadays the TNBC just after last, before 8 to 10 years, TNBC, whenever you see a report of the TNBC, the oncologist would go 10 feet behind, and the surgeons will not like to see the patient once again because the prognosis was so gloomy. But you can connect it. Are you in the audio? So for the last 7-8 years, what I have seen, my practice and also my oncology department, we have not seen any patient deteriorating, even if it is TNBC. It is a fantastic response with the newer adjuvant chemotherapy and this immune modulation, and it is doing an excellent work. I have not seen any patient in recent past deteriorating. So you should not stop, and you should not be discouraged. Rather, you should never talk to this patient that you have got TNBC, your prognosis is very bad. It is not true at the moment.
Yes, yes, sir.
It's
Thank
very
you.
much
And after we have sent the patient to the oncologist, and he offered adjuvant chemotherapy, 3 weekly 4 cycle, followed by external beam radiotherapy. And in this regard, I want to ask our Professor Yaqub Ali sir, would you please comment why this ERBT has been given after doing mastectomy and level 2 axillary dissection? Can you make comment, please? Professor Yaqub Ali sir. Shivli.
Yaqub sir, please.
Yes, okay. Yeah, is he there? Sir, are you here? Professor Yaqub Ali sir, can you hear me?
Okay, I will communicate you to the next question.
So now we are switching to the case number 2. Here, Mrs. Y, 60 years old lady, postmenopausal, having hypertension and delusional disorder, presented to us with 5 into 4 centimeter lump in upper outer quadrant of right breast near areola. It was fixed with skin with nipple retraction and mobile ipsilateral axillary lymph node. So,
sir, also here.
Yeah. Can you request our legendary professor, Professor Margup sir, Margup Sen sir, Sir, please, can you make any comment regarding our second case, please? How we should proceed? And Margub, sir, please. Can you hear me? Margub, sir.
Sir, unmute করুন স্যার। মারগুব স্যার unmute করুন স্যার।
Yes. So she's an elderly lady with a large tumor, the central tumor, which is very difficult to treat, as Professor Rie was talking about, and also has got hypertension and diabetes. Is that disturbed?
Psychiatric illness. Delusional disorder, psychiatric illness, some psychiatric illness.
Psychiatric illness. I think some form of VA can be done in that case. Yes, you do some sort of, let's say, false flap, so that seeing that her breast is not there, that will give her some sort of VA. I will prefer that in that case, because she might get more VA with mentally when the breast is totally removed. Otherwise, you have to remove the whole of the breast. But I will prefer conservation, some sort of conservation. Though it is difficult, though she is elderly, because of mental disturbance, she needs that she will see that the sort of her breast is okay.
Yes, thank you, sir.
That is my
Yes. So we have done again the ultrasonography, and here we can see the malignant mass, and also the mammography. Here in this mammography, we can also see the malignant lesion very clearly, and this is the core biopsy. This is also invasive ductal carcinoma, grade 2. And immunohistochemistry was done. It was ER positive, PR positive, and HER2 negative. So it's a luminal A type. And the metastatic workup we have done: chest X-ray, ultrasonography, abdomen, but we didn't do bone scan or head scan. This is ultrasonography. So the clinical staging here is T4B N1MX. That is, it is clinically, it is stage 3 and 3A. So what should be the treatment plan? Mojit sir?
Yes, I think you should go for new adjuvant chemo radiation, in fact. That's what I would do. But it should be decided in a multidisciplinary team. But I
yes,
think
it's locally advanced breast cancer.
Yeah, yes, locally advanced breast cancer with her psychiatric problem. I think one should consider downstaging this tumor by new adjuvant chemo radiation. But whether it will be only chemo or, and the other thing is that this patient has got another positive side, that she's ER/PR positive. Is that right?
Yes, sir. Yes.
So I think she, in fact, in the first place, we can consider neoadjuvant plus hormone therapy.
Yes.
Progress of this patient. If you can sufficiently downstage this tumor, then you might consider surgery later on, or that will depend on how she responds to this neoadjuvant chemo radiation.
Yes.
And hormone therapy.
Here also Saifuddin sir.
Yeah.
Saifuddin sir also
sir,
here.
Saif sir, can you make comments, please?
Thank you very much for to say something. Okay, I just with my legendary professor, Professor Majid sir and Sanwar sir, I just want to add one thing. After evaluating the status of the tumor to extension of the disease, age of the patient, and also psychiatric problem, new adjuvant therapy is preferred first, then go for operative treatment, and then adjuvant therapy, especially hormone therapy. That will be the recommended actually. But there are so many options, but three things is very important. Age of the patient, further radiotherapy is very difficult and less responsive. Patient is psychologically compromised. And for this reason, we could not offer any conserving surgery. We could not offer further radiotherapy or any other adjuvant therapy because of the limitations of the patient. I want to say our Modi sir is recommended nicely. This patient needs multidisciplinary approach to recommend up to a standard treatment like this. Thank you very much.
Yes, thank you, sir. Our case number 3, Mrs. Y, 30 years, young lady, mother of 2 children, breastfed for 2 years, no comorbidities, family history insignificant, hard fixed lump involving almost whole breast with skin fixity and beauty orange appearance, hard fixed lymph nodes in ipsilateral axilla. So this is an advanced case. This is our mammography. Clearly showing the malignant changes and also involvement of the skin. We have done FNSC for this patient. It was ductal carcinoma. And also the FNSC from the axillary lymph nodes. It was metastatic poorly differentiated carcinoma. And this is the chest X-ray showing multiple nodules. So it's suggestive of metastatic lung disease. CA15-3 was also raised. So we have also done the core biopsy. Histopathology was invasive ductal carcinoma, and immunohistochemistry report was ER positive, ER negative, and HER2 positive. So it's luminal B type. And the clinical staging T4B N2 M1. And that is, it is stage 4 disease, advanced metastatic disease. Yeah. Yaqub Ali sir, please can you make comment regarding the management of this patient?
Professor Yaqub Ali sir.
Yaqub Ali sir, please.
Please unmute, sir. Please unmute, sir. He is connected but muted.
Okay, so can I ask again, Professor Sanwar sir?
That's okay. Yes,
Yeah.
connected now.
Okay,
Yes,
okay.
thank you.
Sir, please. Yeah.
Thank you, sir. Assalamu alaikum. In that case, it is a stage 4 disease, and I think it should be treated by neoadjuvant chemotherapy. Then some surgical opinion, surgery, and surgery, and also hormone therapy, or maybe radiotherapy, maybe given.
So she is HER2 positive also.
HER2 positive. We can also add it with Herceptin too. Herceptin drugs with chemotherapy, 3 weekly, 6 milligram per meter square body surface area, up to 1 year. In case
which one we should give first? Whether we will give all this simultaneously or one by one or something like that?
Simultaneously with chemotherapy, with cytotoxic drugs, and also Herceptin. simultaneously. After 8 cycles of chemotherapy, and then Herceptin may be continue up to 17 cycles on year.
Any other comment from our senior sirs or professors or panel of experts?
I want to discuss a little with Professor Yakub. What is the combination of chemotherapy you try in this type of advanced stage of this disease? And the patient is 30 years, only 30 years.
It may be AC, adriamycin and cyclophosphamide. If she has no history of ischemic heart disease, and 4 cycles, followed by taxane, paclitaxel or docetaxel, 4 cycles.
4 cycles. And then
or TAC, taxane, paclitaxel, cyclophosphamide, and doxorubicin. If it is a TAC, then in that case, 6 cycles.
After this 8 cycles, what other drugs you will try for the rest of the year?
And other drug, Herceptin, maybe continue up to 17 cycles, 3 weekly, up to 1 year.
So of course, definitely you will look for how the lesions are regressing, or they are responding, or it is spreading into these other areas also.
After 3 cycles, we evaluate the tumor is responding or not. I should continue these drugs, or it may be, it may be changed.
From your experience, what is the prognosis in such a case?
In case of stage 4 disease, prognosis it is metastatic disease. Metastatic overall survival about 18 months. Usually 18 months.
In this particular case, as the picture is 30 years old, lady mother of 2, what the prognosis you predict?
And as it is metastatic disease, it may survive for 5 years. And in that case, 5 years survival is about 20 to 40%. Overall survival.
It's a poor prognosis disease.
Yes.
Professor Moses wants to talk.
I wanted to say one thing. That is, after you have given him this chemotherapy and also your Herceptin, you are going to reassess this patient, the response, because you do not know about the response at this stage. But if this patient does show good response, that is, if the primary regresses, and with chemotherapy and hormone therapy, it is also likely, you cannot be sure, but it can happen. The miracle can happen. There can be regression of the secondaries also. And because somebody mentioned about the scope of surgery, one should consider surgery only if there has been regression of the primary and also the secondary. And what is your experience as an
oncologist
about the response of this patient to the chemotherapy and the hormone therapy, especially a patient who is HER2 positive? And I would imagine that there could be good response, although you cannot predict it. But what is your experience? That's what I want to know. And then I'm going to make further comment about the further management of this patient.
Okay. So thank you, our panel of experts and all the senior professors for discussing in the tumor board. After listening the 2 lectures regarding the advanced management of breast cancer, in fact, I want to go back because actually we are standing far behind. If you see, these are the cases still in our country. These kind of patients come with such advanced diseases. So, and also it is true that also some patients, the patients are becoming aware day by day. So some of the very early cases also coming. So we should learn the newer and newer advanced techniques to give the best possible treatment to our patients. And in this regard, I want to say that in fact, we are lagging behind. Really, we are lagging behind because of so many causes, and we don't have the infrastructures to go. Like if I give one example, we don't have the frozen section facilities. Without frozen section facilities, how we can start the risk conserving surgery? And we also not having sufficient radiotherapy, although it has come to our hospital very recently, but the patient burden is very much. So in this regard, as there are so many legendary professors, senior teachers here present, so I want to request them that if they talk with the policy makers in the government level and also in the non-government levels to do something for the negotiating and to arrange the supportive measures which will help us to do such procedures to help our patients. It will be very much helpful for us. And in this regard, I also want to request Society of Surgeons of Bangladesh to take some steps, because we are still behind, so many years behind. Still, only we are doing mostly the mastectomies. So I want to request them to help us in this regard. So in conclusion, as my topic was multidisciplinary team or tumor board, it is mandatory for the optimal management of a breast cancer patients, and each and every patient should be reviewed by the MDT before starting the breast cancer management. So thank you for your
Dr. Sakara, I have got a question to ask to you. In multidisciplinary team, though
Yes.
you have given this outline and it is the practice of that, is there any role of the patient? Do you want to listen to the patient also?
Yes, sir.
In
Yes, sir.
deciding
Of
the
course, we will
multidisciplinary.
talk with the. Yeah. Yes, sir. Of course,
So,
we will take the decision after talking with the patients. But in fact, they are not in the team of the multidisciplinary team. After meeting with the multidisciplinary team, the decision we have made, we must talk with the patients whether they are also arguing, they are also ready to accept that management plan, or they want to change it, or they have something to argue with us. We must talk with them before the implementation of that decision. Thank you.
Patient's option and the willingness is also a matter. I'm sure you remember the Angelina effect.
Angelina Jolie, yes, sir.
Angelina Jolie. Do
Yes.
you remember it? You see,
Yes, sir. Yes, sir.
it is the patient's will,
Yeah.
Angelina's effect, and in all this, the patient has got the right to accept or not to accept. So, with the multidisciplinary team, there must be a corner is left, not to call her or him, but you must have a scope that what the patient wants and what is the patient's option, and that must be included in the multidisciplinary team.
Yes.
Thank you.
Yeah, Shakira, just I want to make one point.
Yes.
That is, we have talked about one of the presentation was breast conservation. That is very good indeed.
Yes.
But not be done exclusively by the decision of the
Surgeon.
Sorry, I mean,
sir, we can hear you.
Yes. What I'm telling that before we consider best conservation, pre-condition that must be fulfilled. That is, we must have the decision taken in
mouthpiece-টা একটু কাছে নেন স্যার, মুখে mouthpiece-টা একটু কাছে নেন স্যার। স্যার,
decision best conservation is very much in vogue in the developed country, and we are also doing best conservation. But the best conservation to be useful for the patient and effective for the patient insofar as overall survival and recurrence-free survival is concerned, this decision has to be taken in a multidisciplinary team meeting. And each and every patient has to be individualized insofar as the decision for breast conservation is concerned. And in our country, we have certain problems. For example, if you conserve breast, because in the patient that you presented with family history, this will be absolutely wrong to go for any decision without having the genetic status of the patient, BRCA gene, and also before you decide on a surgical treatment, we must have an idea about the receptor status, hormone receptor status, and HER2 status. So these things has to be imposed or ascertained that we have a multidisciplinary team. We have got all the investigation that are necessary before actually you embark upon a scientific course of surgical action. And you have quite rightly said that the society should play a role here in introducing this sort of multidisciplinary team in all the public hospitals. That we can do. I'll ask the president of the society to introduce that system, and everybody has to contribute in this decision. And Professor Sana Hussain has very rightly said, even before you decide on a multidisciplinary team meeting, you should ask the consent of the patient what she wants, whether she wants a breast conservation or she wants a curative surgery where there will be, well, curative surgery within inverted commas, I must say, because some of the patients with breast conservation, they suffer. I have seen even in the developed country, they want to get rid of the tumor. They have got a popular belief that if the breast is left, the tumor might also be left. But that's not the real situation. Tumor will not be left, provided we can have recourse to all the facilities before we This is the point I wanted to make. And the counseling of the patient about the pros and cons of breast conservation has to be made with the patient before we
offer
decide in a multidisciplinary team. Thank you very much.
Thank you.
Dr. Shivli.
Thank you, Dr. Shakir Ahmed, ma'am, for your nice presentation and all the participants for this lively discussion. And now it's question and answer session. And there are lots of comments and questions in the chat box. And almost all the comments are full of praise for the presenters and the SOLT. Now, I would like to request Professor Konut Kantiburwa, sir, an icon and renowned neurosurgeon, to say something about this program. Professor Konut Kantiburwa, sir.
Mr. President of the Society, Professor Tauhidul Alam, and he's also the president of the chairman of this webinar, and the honorable speakers, Dr. Samia Mubin and Dr. Diptendra Sharkar, and case presenter Dr. Shakira, and legendary our expert who have given their opinion on the different cases, and participants, and ladies and gentlemen, very, very good evening to you all. It is my honor to be present in this August session. I was present throughout the whole session, and I have seen the presentation was so nice. The presenter has given an elaborate presentation on their topics. I congratulate them. I am very much grateful to them for their wonderful presentations, and also to Dr. Shakira for presenting it two or three cases, and the opinion given by our legendary expert, Professor M. Majid and Professor Sanawar Hussain, Professor Marguf Hussain, and Professor Saifuddin Ahmed. I want to express my thanks and gratitude to them. At the same time, I am also extending my heartfelt thanks and gratitude to the organizers and President and Secretary General of the Society for organizing this month-long session on breast diseases. I must congratulate them. Thank you for inviting me. Thank you very much.
Thank you, Professor Konokanti Burwa, sir, for your excellent encouraging speech. Respected all, October is Breast Cancer Awareness Month to aware women to come forward for early detection. I believe this should be the time to aware ourselves also, to develop ideal setup for breast cancer care. Now I would like to request Professor A.H.M. Tawhidul Alam, sir, to give his speech and conclude this session.
Thank you, Dr. Shivli. Today, Chief Guest, Professor Konokanti Borua, Honorable Vice Chancellor of Bangabandhu Sheikh Mujib Medical University. I thank Professor Konokanti Borua, sir, for bearing with us for the long 2.5 hours with us and enjoying the session. Actually, today's session was very interactive. Our 4 panelists, they have participated well in the discussion, and all the presenters, they have presented very nicely in their respective fields. Particularly, our foreign speaker, he has described the beyond the conservation of breast surgery. He has shown his own work, particularly work beyond, I should say, beyond conservation. Definitely, time will say the result and everything of that particular surgery. And with this, we had also with us our senior professor, Professor M. Majid and Professor Marguf Hussain, and other professors are there, Firoz Kadir and Professor Muttalib are there. And I thank everybody for joining, for bearing with us for a long time. And definitely, I must thank my secretary for celebrating this breast cancer, this awareness month by arranging 4 webinars covering starting from benign breast disease to advanced breast conserving surgery. We have covered almost every aspect of the breast in this 4 webinars. And I would request all the participants, all our senior teachers, to join with us in the month of November. We have a plan of organizing a series of webinars on endoscopic surgery. And, it will be comprising of 4 series, 4 deliberation. And every Friday, we are planning to organize this. And with these few words, I thank everybody, every teacher, and everyone for
before
their
Tawhid,
presence with us, sir. Please, sir.
Before
sir.
You conclude, please convey our all the thanks and the gratitude to our foreign speaker, Dr. Dipendra Sarkar,
definitely, sir.
And also our local.
Sir, definitely, sir.
Sir.
That I'll do, sir. That I'll do, sir. Our special thanks to Professor Dipankar Sarkar, because for participating with us, and definitely he has invested our knowledge and experience, and definitely our oncoplastic breast surgeons, they are very much encouraged by seeing his presentation, and definitely they will adapt these sorts of surgery in our country. Some of our surgeons are doing it definitely with this presentation. definitely our part.
If I am
part of this.
If I am allowed to make a single comment, sir.
Please go ahead.
Sir, I must confess that a physical conference can never be. I mean, that should be our first choice. আমরা যেই মুহূর্তে এই প্যান্ডেমিক শেষ হবে, আমি আশা রাখবো আমরা সবাই আবার সাক্ষাতে দেখা করব এবং আমরা এই ডিজিটাল মোড নয় সামনে বসে আলোচনা করব। আমি নিশ্চিত আমরা এপার বাংলা ওপার বাংলা এই প্যান্ডেমিককে জয় করব এবং ব্রেস্ট ক্যান্সারকেও জয় করব। অসংখ্য ধন্যবাদ আমাকে ইনভাইট করবার জন্য।
You are welcome.
You are most welcome. Last of all, I'd like to thank RAS Television and ACI Pharmaceuticals for their kind supports of the organizing this series of webinar. 4 webinars they have very nicely arranged, and they have organized everything. And my special thank to ACI and the RAS TV people. With these few words, I would like to conclude this session over here, and I invite everybody in advance to enjoy our next webinar in the month of November. Thank you, everybody.
Sir, আমরা যে
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe